Bismillahirrahmanirrahim. Assalamu alaikum. Today we will be discussing chapter 63 of Rooks dermatology, which is about nutritional deficiencies affecting the skin. I will be sharing about vitamin B complex in this lecture. Please head towards page 63.13, vitamin B1. Vitamin B1, also known as thiamine, it's a water-soluble vitamin. It performs two important functions. It acts as a coenzyme for metabolism of carbs, lipids, and proteins, and it also acts as a coenzyme for synthesis of the NADPH. NADPH is an important molecule which is involved in various metabolic processes, and it also prevents the cells from the oxidative stress. Vitamin B1 is involved in these two metabolic processes. The synonyms for vitamin B1 are thiamine and aniurine. The dietary sources of vitamin B1 include whole grain, wheat, peas, beans, potato, and fish. After obtaining thiamine in the diet, it enters into the intestine. From there, it is absorbed from the enterocytes and is taken to the peripheral tissues where it is used as thiamine pyrophosphate, which is the active form of thiamine. Move on to the next page, please. Regarding epidemiology, thiamine deficiency is rare in developed countries. It is more common in the underdeveloped countries because of poverty and decreased nutritional intake. And there's no age, sex, or ethnic predilection. It can occur in all age groups, and it can happen in males and females with the equal proportion. Regarding the predisposing factors, whenever there is deficiency of any nutrient, the major causes include either there is decreased dietary intake of that nutrient, or there is a decreased absorption of that nutrient, such in cases such as in malabsorption syndrome, or there is decreased peripheral uptake of that nutrient because of some drug interacting with it, or because of some critical illness, systemic illness, because in that situation there is increased metabolic requirement of that nutrient. Other conditions where there's increased metabolic requirement includes the conditions like malignancy in case of hyperthyroidism and in critical systemic illnesses. The two more important predisposing factors in deficiency of thiamine are the alcohol consumption and in the infants who are breastfed with thiamine deficient mothers. Now, how does it present? There are few general features that you see in every deficiency of every vitamin B complex, which include fatigue, irritability, lethargy. Because why? Because the thiamine is involved in metabolic processes and involving the carbs, lipids, and proteins. Whenever there's deficiency of these nutrients, there is less metabolism of these macronutrients and lesser production of energy. The patient will be lethargic, apathic, loss of emotions, and the patient will be irritable. Uh, there's going to be nausea, vomiting, and also features of glossitis in thiamine deficiency are seen. Regarding the clinical variants of, of thiamine deficiency include the wet beriberi, the dry beriberi, and the infantile beriberi. These three are the major clinical variants of thiamine deficiency. In the wet beriberi, there is prominent cardiovascular involvement. The patient, the thiamine deficiency causes dilated cardiomyopathy, which results in cardiac failure, and the patient presents with orthopnea, PAD, and dyspnea, and with peripheral edema. There is accumulation of the fluid in the peripheral tissues, hence named as wet beriberi. And in the dry beriberi, there are prominent neurological features, which include There are prominent neurological features seen in the dry beriberi, which includes the areflexia, hyporeflexia, and paresthesias, and also hypotonia and generalized emaciation is seen in case of dry beriberi. And there is also another presentation of, please pardon me for this. Another acute presentation in case of thiamine deficiency is vernix encephalopathy, where a patient presents with acute confusional state, and there's a classic triad of ophthalmoplegia and ataxia and confusion. These three are the findings that you see in vernix encephalopathy, whereas an infantile beriberi. In the infantile beriberi, there is prominent aphonia due to involvement of the vagus nerve, and there is also cardiac involvement and also absence of the deep tendon reflexes. Regarding the complications, the late complications of thiamine deficiency include Korsakoff syndrome. In this, the patient presents with ataxia, with confusion, and with amnesia and memory loss, that is dementia. This happens when there is chronic deficiency of thiamine. The prognosis is generally good if the disease is caught earlier, and significant neurological progression may be irreversible if untreated. Now, how do you investigate a patient with thiamine deficiency? You assess the transketolase activity, erythrocyte transketolase activity. You give them a thiamine shot before and you assess the transketolase activity before and after administration of thiamine pyrophosphate. And if there is increase in thiamine pyrophosphate effect, then this means that there is deficiency of thiamine. Management, the daily dietary requirement for thiamine is 0.5 milligram per 1000 kilocalories, which makes 1 milligram per daily dose. So in case of deficiency, we give 1 milligram per daily. However, in case of beriberi, we administer IV or IM thiamine up to 50 to 100 milligrams on daily basis for 1 to 2 weeks, that is 7 to 14 days, and then we shift the patient to oral supplementation unless the symptoms have resolved. Now the next vitamin, vitamin B2, also known as riboflavin. It's also a water-soluble vitamin, and it's an important cofactor for various cellular redox reactions and in vitamin B6 metabolism. There are two active forms of riboflavin, riboflavin mononucleotide and flavin adenine dinucleotide. The dietary sources include milk, dairy products, fish, meat, eggs, green leafy vegetables, whole grains, enriched breads. Among these, the richest sources are the milk, the dairy products, and the meat. Again, there is no age, sex, or ethnic predilection in riboflavin deficiency. The associated diseases include increased plasma homocysteine levels, impaired iron handling and anemia, cardiovascular disease, night blindness, and developmental abnormalities, peripheral neuropathy, and even malignancy. Because why there is increased plasma homocysteine levels? Because riboflavin, it has a role in conversion of homocysteine to methionine. When there is decreased riboflavin, there is accumulation of the homocysteine in the serum. That's why this causes homocystinuria. The factors which predispose to thiamine deficiency are again similar as previous one. There is if there is decreased dietary intake, or there is malabsorption, or there is phototherapy. Now in phototherapy, what happens is that there is photodecomposition of the riboflavin, and that's why there is acute deficiency of vitamin B2 in patients undergoing phototherapy, especially in the neonates. Besides this, it can also happen in elderlies, in alcoholics, because alcohol prevents the absorption of the riboflavin in the enterocytes. That's why there's deficiency in the alcoholic use disorder patient and people with an alcoholic use disorder. And also patients who have some eating disorders like bulimia nervosa or anorexia nervosa, they're also at an increased risk of deficiency of riboflavin. And breastfed infants of riboflavin deficient mothers, they are also at risk. And besides this, some drugs that interact with its absorption include the tricyclic antidepressants and borate. Borate is a compound which is found uh, in the pesticides and in the fungicides. And in case of acute ingestion in suicidal attempts, you see acute deficiency of riboflavin because of this borate. Borate found in that fungicides. It makes complexes with those riboflavins, and it binds with them, and it causes decreased serum level of riboflavin. Now, how does it present? There are two presentations. One is acute and one is chronic. In the acute presentation is due to acute borate ingestion, whereas the chronic deficiency presents months after the riboflavin deficient diet. In the acute, there is going to be deep red erythema, epidermal necrolysis, and mucositis. Whereas in the chronic, there is going to be the top three findings that you see in each and every vitamin deficiency, which is angular stomatitis, cheilitis, and glossitis. These three findings we are going to find. Besides this, the earliest finding, cutaneous finding that you see in vitamin B2 deficiency is the dyssebacia of the nose. Now, dyssebacia is a condition where there you see, I hope it's there in the figure. It's a condition where you no, it's not there. I'll explain it to you. The sebaceous is a condition where you see plugs of sebum projecting through the skin because of dilation of the sebaceous gland. This condition is also known as seborrhea spinolosum, or shark skin. This is the earliest cutaneous feature which happens in the vitamin B2 deficiency. Besides this, there is also SD-like eruption in vitamin B2 deficiency and angular stomatitis. It begins at the corners of the mouth, which then extends laterally and which even macerate and bleed in the long course. Again, glossitis may also occur in vitamin B2 deficiency. And now, what are your differentials going to be in a patient who presents with such findings? Other B complex vitamin deficiencies will also present with stomatitis, cheilitis, glossitis, as I mentioned just now, and SD-like eruption, including pyridoxine deficiency. Your top differential are going to be other vitamin B complex deficiencies, including the pyridoxine deficiency here. Now, the disease, it carries an excellent prognosis, and there's very good prognosis with riboflavin supplementation. Regarding investigation, we send the erythrocyte glutathione reductase activity, which is going to be low in case of deficiency. Management, the recommended daily intake is 0.3 to 1.6 milligrams. If we are treating an infant or child with vitamin B2 deficiency, the dose is 1 to 2 milligrams per day. And in adults, it's 10 to 20 milligrams per day. Moving on to the next vitamin, vitamin B3, also known as niacin. It's also a water-soluble vitamin, and it's an important cofactor for NAD and NADP. NAD and NADP are involved in various metabolic processes in the body. There are two sources of vitamin B3. Half the source is from endogenous synthesis, or the gut flora that we have, and half is achieved through the dietary sources. The richest sources include the meat, fish, and the dairy products, among others that have been mentioned over here. The deficiency of niacin results in pellagra, which is characterized by four Ds. These four classic features are found in pellagra, which include dermatitis, diarrhea, dementia, and, if untreated, even death. Two diseases which are associated with niacin deficiency are the heart nerve disease and the carcinoid syndrome. Heart nerve disease is a rare autosomal recessive disorder where there is defective neutral amino acid transport system which results in malabsorption of the tryptophan. Tryptophan is an amino acid which is used in the synthesis of niacin. If there is deficient tryptophan, there is going to be decreased niacin levels. This is an this is a genetic disorder, heart nerve disease, and in carcinoid syndrome, this is a serotonin-producing tumor where because serotonin is also made from the tryptophan, all the tryptophan is shunted into the synthesis of serotonin, resulting in decreased tryptophan levels in the serum and consequently decreased niacin levels in the blood. So, in the carcinoid syndrome and in the heart nerve disease, you somewhat have the similar pellagra-like dermatitis presentation in these patients. Again, there is no age, sex, or ethnic predilection for niacin deficiency. The predisposing factors are the, again, decreased dietary intake, or if there is defective absorption, as in case of malabsorption syndrome, or in IBD, or in patients who have celiac disease or Whipple disease, or they have undergone any bariatric surgery which halts the absorption of these nutrients from the gut, or there's some eating disorder, and again alcohol, the main culprit, and besides this, there are some drugs which interfere with the absorption of the of niacin. The among which more notable are the isoniazid, 5-fluorouracil, 6-mercaptopurine, and the anticonvulsant drugs and convulsant drugs and the antidepressants. How do anticonvulsants they interfere with the absorption of the niacin? Because they induce the hepatic enzymes, and due to which the absorption of the niacin is affected. Now this image shows the heart nerve disease. You can see dermatitis in the photoexposed areas because of a mutation in the gene which is responsible for transport of the amino acids through the gut, resulting in decreased tryptophan levels and consequently decreased niacin levels as well. Clinical features, it is going to be it is going to present with very painful or pruritic erythema or edema, and which in severe cases can even transform into vesicles and bulla formation. Ultimately, the lesion is transformed into hyperpigmented and keratotic plaques in pellagra. There's also involvement of the face in butterfly distribution, and there is, as you can see, hyperpigmented keratotic plaques in the photoexposed areas. These are the dorsal aspect of the hands, showing pellagra dermatitis. There is also facial involvement in the butterfly distribution, and also involvement of the neck and the upper chest, a condition known as castle necklace. And again, vitamin B deficient, typical manifestation, angular stomatitis, cheilitis, and glossitis, along with oral ulcers. There have been reported few cases about half and half nails involvement as well. Now your top differential is going to be pyridoxine deficiency and other photosensitive dermatosis because of involvement of the photoexposed areas. The complications, there severe neurological complication may occur if it's untreated, which includes stupor. Patient may develop stupor and even get comatose. The disease is progressive and can prove fatal if it's untreated. And death even may occur within 4 to 5 years if it's untreated. Now, how do you investigate a patient with pellagra? Pellagra is mainly a clinical diagnosis. You examine the patient, and based on your typical findings of pellagra, like dermatitis in the photoexposed areas and angular stomatitis, cheilitis, and glossitis, uh, you, you immediately pick up the diagnosis that it's niacin deficiency. But besides this, if you are asked to perform any laboratory test for this, you perform N-methylene, nicotinamide, and 2-pyridine levels in the urine. These are metabolites of the niacin, which are urinary metabolites, niacin metabolites, which are found in the urine. They're going to be reduced level of these metabolites in case of niacin deficiency. Now, how do we manage a patient with pellagra? The recommended daily intake is 13 to 20 milligrams. In case of deficiency, we administer 500 milligram per day of nicotinamide or nicotinic acid over several weeks. The neuropsychiatric symptoms, they are the first to resolve. They resolve immediately within 1 to 2 days of the treatment, while the cutaneous treatment may take some time to remit. Vitamin B6, also known as pyridoxine. It is available in three forms: pyridoxine, pyridoxamine, and pyridoxal, as you can see over here. Now, it's an essential coenzyme for the conversion of tryptophan to niacin. Hence, the presentation in this disease is in deficiency of vitamin B6 is going to be pellagra-like, because it acts as a as a coenzyme for conversion of tryptophan to niacin. There's going to be decreased niacin, and again, pellagra-like dermatitis is going to be there in pyridoxine deficiency as well. There is going to be It also acts as a essential coenzyme for fatty acid metabolism and in gluconeogenesis, in the decarboxylation and transamination of amino acids and prostaglandins, and in neurotransmitter synthesis. All these are very important functions that it's performing. Now, what are the dietary sources? The dietary sources of vitamin B6 include the meats, vegetable, nuts, and the whole grain. There is no age, sex, or ethnic predilection for deficiency of vitamin B6. The predisposing factors include the decreased dietary intake and malabsorption, certain medications like isoniazid, hydralazine, or penicillamine, or oral patients who are taking oral contraceptive pills, and in alcoholics, and seen in patients with renal failure. How does a patient present now? In case of acute deficiency, again, as I mentioned earlier, because of deficiency of these nutrients, the person will have lethargy and anorexia, nausea, and vomiting, and confusion, and loss of emotions, and apathy, and increased somnolence. These are the general features that are going to be there in early deficiency of vitamin B6. However, in However, if the deficiency is prolonged, there's going to be seborrheic dermatitis like eruptions, which involves the face, scalp, neck, shoulders, buttocks, and the perineum. Again, angular stomatitis, glossitis, and cheilitis will also be observed in vitamin B6 deficiency. And there is significant overlap with niacin deficiency and a pellagra like dermatitis. Patient may also present with anemia in certain cases. Your top differential is niacin deficiency in case of vitamin B6 deficiency. Now, the complications include the complication includes refractory seizures. Like now, let me explain how deficiency of pyridoxine causes refractory seizures. Pyridoxine is an important coenzyme in the carboxylation of various processes, out of which one of them is decarboxylation of GABA, which is an inhibitory neurotransmitter in the brain, because there is a decreased pyridoxine, resulting in decreased carboxylation of the GABA. So reduced GABA levels, because GABA is an inhibitory neurotransmitter. If its deficiency causes increased electrical impulses in the brain, and increased electrical impulses, due to which patient will present with fits and generalized seizures, which are intractable and difficult to control. Such cases have been more reported in the infants. The disease prognosis is generally good if the disease is caught up early and it's treated promptly. How do you investigate a patient with vitamin B6 deficiency? There are two tests. Either you directly assess the deficiency, or there are indirect methods. Among the direct method, there are going to be low plasma pyridoxal 5-phosphate levels. And in indirect way, you either perform tryptophan load test, or you assess the erythrocyte aminotransferase activity. Management. The daily recommended intake for vitamin B6 is 0.1 to 0.1 to 2 milligrams. In case of deficiency, we do supplementation with the tablet pyridoxine 100 milligram daily until the symptoms have resolved. Vitamin B9, folate. Now this is important. It is also a water-soluble vitamin, and it acts as a coenzyme for metabolism of amino acid, purines, and pyrimidines. The dietary sources include dried beans, leafy green vegetables, beans, liver, and grains. Predisposing factors, let's see. There is no age or ethnic predilection for deficiency of folate. However, regarding sex, pregnant females are at higher risk of developing folate deficiency. That's why they are advised to take a tablet folic acid as soon as the conception happens, or even if they're not pregnant and they're planning to get pregnant, they're advised to take folic acid. Again, the associated diseases include elevated homocysteine levels, as I mentioned, that it acts as a coenzyme in the various processes, out of which one is the conversion of homocysteine into methionine. And if there's deficiency of folate, because active form is tetrahydrofolate, deficiency of tetrahydrofolate results in decreased conversion of homocysteine into methionine. There's accumulation of the homocysteine in the level, resulting in homocystinuria. The predisposing factors: the pediatric population is more at risk of developing folate deficiency, owing to the fact that if they consume overly boiled cow milk, or if they are fed with goat milk. And again, in the alcoholics, and in malabsorption syndrome, and in certain drugs like antifolate drugs like methotrexate and trimethoprim, or in patients who are taking oral contraceptive pills. Again, anti-epileptic drugs, they're also the culprit. More notable are the phenobarbital, phenytoin, and carbamazepine. Again, they have mentioned because they induce the hepatic enzymes and diminish the folate stores. Now, how does it present? There are two major presentations of folate deficiency. One is hematological and the other is mucocutaneous. In the hematological manifestation, we'll see megaloblastic anemia, and there's going to be hypersegmented neutrophils, neutropenia, as well as thrombocytopenia. And the mucocutaneous findings include the glossitis, angular cheilitis, mucosal ulceration, perineal seborrheic dermatitis, hair depigmentation, and mucocutaneous hyperpigmentation. The top differential that we keep in mind with these features is vitamin B12 deficiency. It can 100% mimic with these findings. However, there is a very major difference between the two. In case of vitamin B12 deficiency, there are going to be neurological features which are not there in the folate deficiency. Complications, very important. It may result in fetal neural tube defects because folate it has to do with the neural tube genes that are involved during organogenesis. Folate helps in the development of those genes. Deficiency of folate results in neural tube defects, among which the topmost are the spina bifida and the anencephaly. Folic acid supplementation is typically curative of folate deficiency. How do we investigate? We send serum and red blood cell folate levels, and in the peripheral film, we may also uh, mm, we may also see presence of hypersegmented neutrophils. Management. The recommended daily intake of folate is 65 to 600 microgram per day, depending on the age. In case of deficiency, we prescribe 1 to 5 milligrams of tablet folate daily. Vitamin B12, also known as cobalamin. It's also a water-soluble vitamin, and it's also an important coenzyme in metabolism of DNA, proteins, lipids, and carbs. The dietary sources includes eggs, milk, beef, liver, and organ meat. If you observe, you don't see any plant origin source for vitamin B12. It is purely the source is purely animal origin. The associated diseases that we see in B12 deficiency are the acquired pernicious anemia and the autoimmune gastritis. Now, what happens is when we ingest B12 through the diet, it is taken into when it enters the stomach, because of lower pH of the stomach, the B12 it separates from the food and it binds to the intrinsic factor in the duodenum, and from there it is taken up by the enterocytes and binds to the transcobalamin 2, which is then released into the portal circulation. Regarding epidemiology, they have mentioned that there is no age, sex, or ethnic predilection. Regarding ethnic predilection, they have mentioned that it is common in individuals of European and African ancestry, but we can say that it is also common in those ethnic groups who are pure vegetarian and who do not consume non-veg food. It is also commonly seen in those ethnic groups. Now, the predisposing factors. What are the conditions that predispose to vitamin B12 deficiency? Inadequate intake, malabsorption, and inborn errors of transport and metabolism, mutation in gastric intrinsic factor gene. These are the conditions that predispose towards vitamin B12 deficiency. Also, it is common in those who take antacids, like the patients who are on chronic PPIs and H2 histamine blockers, because there is decreased gastric acid production in these patients, which prevents the dissociation of B12 from the food, hence decreased availability of B12s in the peripheral tissues. And in case of chronic diarrhea, such as in IBD or in celiac disease, Whipple disease, and Zollinger-Ellison syndrome. And among the genetic causes, it occurs in pernicious anemia. We know in the pernicious anemia, there are antibodies against the gastric intrinsic factor and the gastric parietal cells, due to which there is deficiency of the vitamin B12. Now, how does a patient present? A patient would present with fatigue, weakness, and with glossitis. There are going to be three major manifestations. Again, just like vitamin B9, like folate, there's going to be hematological manifestation and mucocutaneous manifestation. These two manifestations are exactly just like vitamin B9 or folate deficiency. There's going to be megaloblastic anemia and hypersegmented neutrophils, and again, Hunter's glossitis, angular cheilitis, hair depigmentation, and mucocutaneous hyperpigmentation. Regarding their neurological findings, because there is decreased production of the myelin sheet due to deficiency of vitamin B12, there's decreased production of myelin sheets, and this results in defective nerve impulse conduction in the nervous tissues. With this results in paresthesias, numbness, and tingling. And because of demyelination of the spinal cord, it affects the dorsal column medial lemniscus and the lateral spinal thalamic tract, due to which there is a improper sense of position, vibration, and fine touch. And besides this, if it's untreated, this may even result in spasticity, paraplegia, and incontinence, and may also result in increased sleepiness, and loss of emotions, and dementia, and even psychosis. Your top differential in B12 deficiency is folate deficiency, because these features encompass both folate deficiency and the vitamin B12 deficiency. The main differentiating point between the two is the presence of the neurological features, which is found in B12 deficiency, but not in folate deficiency. Now, the complications include advanced neurological diseases, which may be found if it's untreated. Disease course and prognosis. The prognosis is good with early recognition and treatment of the condition. Now, investigations. There are 4 investigations that we do in a patient with B12 deficiency. We send the serum cobalamin levels. Normal levels are 200 picogram per ml. In case of deficiency, it's going to be lesser than 200 picogram per ml. And we do the Schilling test here, Schilling test. And this is test where we assess the absorption of the vitamin B12 in the intestine at the level of the duodenum. And the other test is we assess the presence of anti-intrinsic factor and anti-parietal cell antibodies to assess for pernicious anemia. And also we do the biopsy of the gastric mucosa. This is an invasive procedure. And for this also we assess if there is an autoimmune or atrophic gastritis or not. Management. The daily, the recommended daily intake is 0.4 to 2.8 micrograms. If there is deficiency, we provide the patient. There are two sources. Either we provide them with parenteral or we give them orally. If it's parenteral, we give 8 to 10 milligrams daily to weekly, and then monthly 1 milligram thereafter. And in case of if we are providing them with oral, we give them 1 to 2 milligrams daily until the symptoms resolve. Moving on to biotin, which is also a part of vitamin B complex. Vitamin B7, vitamin is also known as vitamin B7 or vitamin H. There are two names for biotin. It is also a water-soluble vitamin, and it is an essential cofactor for the carboxylase enzyme, which are involved in the fatty acid synthesis and in gluconeogenesis and in amino acid catabolism. The dietary sources of biotin include this biotin also has two sources. One is the endogenous source, that is, it is made from the gut flora, and the exogenous source that we obtain through the diet. The diet, which is rich in biotin, includes the eggs, cow milk, soybean, liver, mushroom, peanut, hazelnut, and the walnut. Now, what happens is that the dietary biotin that we consume, it is bound to the proteins. When we ingest this, It enters into the intestine where it is acted upon by pancreatic biotinase. From there, this enzyme releases the free biotin, and that biotin travels to the liver where it complexes with the carboxylase enzymes via holocarboxylase synthetase. The purpose of mentioning this cycle is to tell you that whenever there is deficiency of biotin, it's either acquired because of deficiency in the dietary level, or it's congenital or inherited because of deficiency of these two enzymes, which is biotinase and holocarboxylase synthetase enzyme. Now, if we discuss the deficiency at the age at which this deficiency occurs, in case of inherited deficiency of these enzymes, the holocarboxylase synthetase enzyme, this presents rather in the earlier course of life, in the first 6 weeks of life, whereas biotinase, it presents in early childhood or infancy, typically after the 3 months of age. And there is no sex or ethnic predilection for deficiency of biotin. Now, the predisposing factors because of excessive intake of the raw egg white. How? Because the egg white contains a glycoprotein known as avidin, which tightly binds the biotin and prevents its absorption in the intestine. When we cook the eggs, this bond is broken, and then biotin is freely available for absorption. Besides this, unsupplemented parenteral nutrition. In patients who are on total or peripheral parenteral nutrition, if that is not topped up with biotin, or if the infant formulas are not topped up with biotin, this also results in deficiency of vitamin B7. Uh, this may also happen in patients who are taking prolonged courses of antibiotic. Why? Because antibiotic, it disrupts your gut flora, so half of your source of endogenous synthetic biotin is disrupted. Therefore, deficiency of biotin is seen in those who who have history of prolonged antibiotic courses. And again, can also happen in patients who are taking anticonvulsants. Now, how does it present? It presents with erythematous and scaly periorificial dermatitis around the eyes, and with nose, mouth, and the anus. Besides this, it also may present with alopecia, with glossitis and conjunctivitis. And because of lack of energy, patient may be lethargic and having myalgias, nausea, vomiting. And if you particularly speak about the deficiency of the enzymes at the neonatal level, deficiency of holocarboxylase synthetase or the biotinase, be it holocarboxylase synthetase or the biotinase, the features are almost similar, because in both of these, because of deficiency of these enzymes, there is a buildup of upstream acidic products, resulting metabolic acidosis, and also because of this acidic environment, there is disruption of the urea cycle, and again accumulation of the ammonia, causing hyperammonemia. And all these conditions like metabolic acidosis, hyperammonemia, lactic acidosis, they all result in a condition known as metabolic encephalopathy. The child will present with metabolic encephalopathy, with seizures, with fits, and with hypotonia, as you can see over here. Another important feature that we see in biotinase deficiency is the hearing loss, which is permanent. If you replace the biotin sources in an infant with biotinase or in a biotinase deficiency, rest of the features are reversed. However, the hearing loss is irreversible. Your top differentials in a patient presenting with these findings is biotin deficiency and zinc deficiency and essential fatty acids, which is omega 3 and omega 6 fatty acids. For example, linoleic acid and arachidonic acid. Those are essential fatty acids. in deficiency of those essential fatty acids, the presentation is going to be similar, just like this. Now, the complications, again, the patient may develop permanent neurodevelopmental deficits, as I mentioned, in biotinidase deficiency. Rest of the features are reverted, but the hearing loss is permanent. Regarding disease course and prognosis, prognosis is generally good with early diagnosis and treatment. However, the prognosis is bad in case of holocarboxylase deficiency. If you do not treat it, the mortality rate is 100%. Now, how do we assess biotin deficiency? We see low serum biotin levels. Normally, the levels are 133 to 329 picomoles per liter. In deficiency, it's going to be lesser than this level. We are going to see urinary ammonia and amino acids, as I mentioned over here. Because of the metabolic acidosis, there's disruption of the urea cycle and buildup of ammonia. That hyperammonemia appears in the urine. We see increased level of urinary ammonia and amino acids. Also, we assess urinary levels of biotin metabolites. Besides this, we also see decreased biotinidase activity in the serum, in the leukocyte, or in the cultured skin fibroblast. And we can also do neonatal screening of multicarboxylase deficiency. Management. The recommended daily intake is 3 to 35 micrograms. In case of acquired deficiency, we give 150 micrograms daily of tablet biotin. And in biotinidase deficiency and holocarboxylase synthetase deficiency, in biotinidase, we give 5 to 10 milligrams daily, and in holocarboxylase, we give 10 to 40 milligrams daily. We take biotin tablets, we crush them, and we can give them per orally through insulin syringes. IV formulations of biotin is also available. We can administer IV biotin as well. The metabolic and cutaneous abnormalities respond rapidly. However, the neurological deficits, such as hearing loss and vision impairment, may be permanent. I hope you all are clear with the deficiency with the vitamin B complex, its deficiencies, and its presentation and its management. Thank you.